Hi everyone, this is Dr. Nicole Delamont, and I'm one of your co-instructors for this course. Today we're going to talk a little bit about undernutrition and COPD, which I think we will realize is sort of underdiagnosed and undertreated, but a really important part of the prognosis and outcomes in COPD. So let's define what an undernutrition state is, because this applies to more than just COPD. There are many chronic diseases where you'll see undernutrition state. And basically what we're talking about here is there's some kind of loss of either macro or micronutrients, which leads to some kind of change in body structure and function. So the idea here is that there's a nutritional deficiency that can be really broad, that changes something about the person, either in their body or in the way that they're moving, and that leads to different kinds of outcomes. So really, if we're talking about what is undernutrition as a broader context, it's not just protein energy malnutrition. So we'll talk a lot today about cachexia in COPD, but this isn't just that. It's not just the depletion of protein or muscle mass. It's not just wasting or depletion or cachexia or sarcopenia. Now, the difference between cachexia and sarcopenia being the loss of body mass versus a loss of muscle mass. It can be a particular macronutrient. So kwashiorkor is commonly seen in children who are protein deficient, and I've done some work in my research about this. So signs and symptoms of that protein-specific deficiency would be edema and ascites. Think about liver disease. While marasmus is more commonly seen as a cachectic disease, so there's a total loss of body mass. Those are the really skinny little kiddos that we've seen. But this can happen in chronic disease as well, right? There's a lot of reasons why people can be undernourished. It's kind of uncommon to see undernutrition symptom in obese patients. There's something called the obesity paradox, which is in one of the articles that I assigned for this lecture. But there's also a chance that you can see obesity with sarcopenia. So you don't necessarily see a change in body composition in undernutrition with these patients. However, they've had a loss of muscle mass that certainly can impact outcomes with the condition. And then beyond macronutrient deficiencies, there are also micronutrient deficiencies. So think iron loss induced anemia, or think lots of different micronutrient deficiencies that can lead to outcomes that certainly have an impact on function. So the proposed definition, and the thing that you probably need to think about when you're considering coding and diagnosing patients, is that you're thinking about a patient who has a BMI of less than 18.5, although this is somewhat disputed, and I did post a paper also that talks about the BODE index for diagnosis of undernutrition and COPD. But it can also be unintentional weight loss, which could also be considered pre-cachectic state in COPD, and low fat-free mass, so think loss of muscle. There are no accepted gold standards for this diagnosis, and the ICD-10 definition of undernutrition state is according to the WHO definitions. I did post a handout about how to code for this as well. So undernutrition in conjunction with COPD is having either a body weight of less than the 80th percentile or less than 90% of ideal body weight, although I think you can argue this diagnosis with a lot of different conditions that we'll talk about in terms of the diagnosis, and you would probably be fine with most insurance companies. So the prevalence is probably higher than what we think it is. It's a largely undiagnosed condition, which is true of all chronic disease states, so think rheumatoid arthritis, etc. And in the paper that I was looking at that was sort of looking at prevalence rates, there were more than 99% of cases that were undiagnosed, about 10 to 40% prevalence in the outpatient population. So this is where we think about prevention, right? In primary care, how can we be looking for patients who are showing signs or risk factors for pre-cachectic states or who are in cachexia when they come to us? And about 30 to 60% of these people are inpatient. And this is sort of a chicken and egg situation in terms of decompensation due to undernutrition, but can certainly impact outcomes, readmissions, etc. This can be a really expensive part of the way that COPD is managed or not, depending on how well it is managed. So this obviously affects prevalence rates. If we're talking about 10 to 60%, that's not exactly helpful. But the more that we can get diagnoses going, the more that we can think about awareness in terms of our own clinical practice, the better this prevalence rate will look. So there are a lot of risk factors for undernutrition that come out of this that are beyond just a person being skinny. People who have an undernutrition state in COPD have an increased morbidity, so worse outcomes with the condition itself. They have increased healthcare utilization. You can imagine that if a person is less well managed, that they would use healthcare more often. There's actually an increased mortality, so people who are undernourished actually die more often, and we know of that in a lot of different conditions. But I think it's important to consider because typically we're talking about obesity as a reason for morbidity and mortality, while in COPD, there's actually sort of an opposite effect. So undernutrition can really increase morbidity and mortality, and that can change also functional consequences. So there are propositions in the literature that say that there's a decreased immune compromise, there's impaired or delayed wound healing, there's reduced erythropoiesis. So you're not just talking about iron deficiency in COPD, cachexia, or an undernutrition state. You need to be thinking about what are the other reasons that this person could have reduced erythropoiesis beyond just iron. And we can talk a little bit more about that, or we can talk offline about that. Cognitive dysfunction and mental health symptoms can also come from this, independent of sort of the way that things are happening, right? So certainly we could imagine that people who had really severe COPD would be depressed or anxious. However, the state in and of itself can be causing this independent of social factors. So, there was a pretty good paper that did some qualitative research about the experience of undernutrition in COPD and what went along with this. And we'll talk a little bit about it throughout the talk. But yeah, it's changed their life. People really struggle when they're not nourished well, when they can't do things, when they can't live their life. And certainly in order to be able to socialize and spend time with friends and do the things that we think of as being associated with better quality of life, there's got to be some state of nourishment. And obviously if you can't breathe, that's an issue too. So if we think about the pathophysiology of this thing, we can kind of break it down into two different parts, both increased metabolism and decreased intake. And the reason for these things can be really highly disputed in terms of what is causing either the increased metabolism or the decreased intake. And I think it's probably a combination of a lot of things. So the increased metabolism can come from both an increased basal metabolic rate, so right, that the amount of calories that we just burn from being alive. So that can actually be impacted both by inflammation and hormonal effects within COPD. So just having the change in lung capacity, just having the physiological changes in the lungs that happens in COPD leads to low-grade systemic inflammation and changes in hormones that can actually increase metabolism, not just work of breathing, although that is a part of the physical activity that can increase metabolism as well, right? So as accessory muscles are having to work more, there is an increased state of metabolism from that as well. There's also a decreased intake of energy and nutrients, and that can come from a lot of factors that we'll dig into, but changes in appetite, dietary intake, even changes in chewing and swallowing that can come from COPD really lead to an imbalance that can lead to changes in nutrition, right? And that can, like I said, either be a cachectic experience where the person loses total body mass, a sarcopenic experience where the patient loses muscle mass, or something that is undernourishment and yet showing other signs and symptoms like in some of the micronutrient deficiencies. So specifically in COPD, we can be talking about, like I said, work of breathing. So, just the gas exchange within the lungs takes about 3 to 7 times more work for the body than in healthy subjects. There's also a change in nutrient-induced thermogenesis. So basically, even the way that patients with COPD metabolize nutrients is different. And in particular, protein takes some work to metabolize. And we know based on the literature that COPD patients actually do use more protein or muscle mass in a lot of cases to get energy. And then there's also that long-term inflammatory response, which we talked about a little bit before. So some of the outcomes are impacted by three different parts of this. So the degree of physiological change in COPD, the degree of physiological change due to muscle mass, and the nutritional intake. So essentially, where is the state of the COPD itself? What is the physiological change within the lungs? And then also, what is the physiological change within the accessory muscles? So we sort of alluded to the fact that if someone has to use more muscle to move air in and out of their lungs due to COPD, in addition to having an exchange of gas that is through a thicker membrane and takes more energy for the body, there's also a change in accessory muscle work that can lead to an increased metabolism. But nutritional intake is a big part of this, and I wouldn't underestimate in a patient who has a lot of really complicated metabolic changes happening, like what's happening in COPD, that there's, a huge impact just from not eating. So the degree of that physiological change in COPD state depends on the stage of emphysema. So this is why it's really important to think about GOLD criteria or even the BODE criteria for COPD diagnosis. It has to do with the impairment of diffusion. So how well can oxygen get from within the alveoli into capillaries and then get that gas exchange going. It also has to do with airflow obstruction. So think about the state of the COPDer. An exacerbated COPDer will have a different degree of physiological change than in a U or in a homeostatically regular patient. So think about where the COPDer is in terms of their risk. And we can go back to some of the prevalence rates like in the hospital, and this may explain why outpatient COPDers have lower rates of undernutrition state than inpatient, because typically patients inpatient, although this may be another chicken and egg situation, would have more states of exacerbation, would have higher rates of nutritional changes. But also that change in muscle mass can really impact things. So for example, in obesity, in sarcopenic obesity, patients may lose muscle mass and then have even more increased work of breathing because accessory muscles are not there to change even just some of the mass and adiposity that we're talking about. You can see a normal BMI with an abnormal fat-free muscle mass, and that's what we call sarcopenia. And so it can look like someone is perfectly fine when they sit in your office. They could have a BMI of 26 or 27 and still really struggle in terms of undernutrition state, which can sort of change or progress as things go on. There's also the concept of general hypertrophy, and that can both be, like I said, in respiratory and accessory muscles, but it can also be in cardiovascular muscle. So if a patient is losing muscle mass in their skeletal muscles, they'll likely be losing smooth and cardiac muscle as well, and that can change digestive function. It can change the way that the heart functions, and you can see in really advanced undernutrition states normal mass patients who then have problems with, for example, CHF or gastroparesis. And so I think that it's important to recognize that this is something that can really quickly progress into several diagnoses that can be related. And again, let's go back to intake, because this can be due to deprivation. So patients with COPD actually have higher rates of food deprivation that are related to socioeconomic status. There are higher rates of anorexia that are independent of smoking. So smoking obviously reduces taste receptors and makes it so that patients don't want to eat, but there are actual changes from that low level inflammatory and hormonal response that can lead to anorexia as well. There's also a lack of social activity and financial support and some basic limited knowledge about nutrition and COPD. And I would say the majority of the patients in my practice don't understand that nutrition plays a big part in how their state of COPD management is really affected. So anorexia, like I said, can have to do with taste, but also there was a study that looked at what were the most common symptoms that really led to anorexia. Dry mouth was a big one, stomach pain, pain in general, and constipation. And so be looking for some of those factors that can really contribute to anorexia. If a patient is saying, I just don't feel like eating, you can kind of dig into some of those symptoms. Women are actually more likely to have diarrhea and smell aversions compared to men, so that's something to look out for as well. And then there's also the concept of breathlessness and fatigue. So when you're breathless, it's really hard to eat, right? Or when you're tired, it's really hard to think about making food. And so that can change the kind of food that people are taking into their diet. In addition, it can even be access to food. So when people are doing Meals on Wheels, for example, that's a great program, but if the food isn't great, then people aren't going to want to eat it as much, right? And then, I think some of it can really have to do with early satiety or appetite. It can be really hard to really force food when someone has that low grade level of systemic inflammation that can impact nutrition. I kind of alluded to this earlier, but swallowing can be a problem. So thinking about the way that people have had chronic steroids, for example, that can really impact the way that smooth musculature works, but also can impact some of those typical movements in the esophagus. And so be thinking about all of those factors. When you're talking to a patient about COPD, it's not just about, oh yeah, you're burning more energy because you have COPD and there are a lot of physiological changes, so just take your medications and exercise and you'll be fine. There's some psychosocial factors, there are some side effects of medication, and there are some natural states within the disease course itself that can really contribute to undernutrition that might need to be addressed. And if you're aware of them, you'll have better outcomes for your patients. So really the prognosis of this isn't great. There's a mortality risk of about 5 times compared to matched control. So that means that even if you've got somebody who's a chronic COPDer and there's one who doesn't have undernutrition, there's one that does, that means that undernutrition state can contribute to 5 times more mortality. That's pretty low. And mean survival is about 2.9 years. This is in contrast to CHF, for example, where the mean survival is about 5 years. So this is even worse than having heart failure in terms of prognosis. We also understand there was a 2012 Cochrane review that increasing weight will reduce risk of mortality. So this is something to aggressively monitor and treat. However, we don't really know about how to do the thing. We know that treatment can incur some benefit. There's an increase in hand grip strength, some expiratory pressure. The 6 to 12 minute walk can improve when patients start having a better state of weight gain or improved nutrition if it's a micronutrient deficiency issue. But we don't really know about quality of life. In terms of labs, you could look at maybe albumin, but that is pretty not evidence-based at best. I think, considering something like oral nutrition supplementation, about 5 to 1,200 calories per day and TID dosing, thinking about really getting protein to the 20 to 50 gram supplementation range for about 8 to 16 weeks of intervention, maybe a little bit longer if not, but I think you'll see the most change within that 2 to 4 month period. It's also important to consider that the baseline diet has a lot to do with the outcome here. So a lot of patients are below the RDA for protein anyway, so getting them up to that 1 gram if they're not there, or even going up to 1.5 grams per kilogram per day could really improve things just because they're not eating enough in the first place. In terms of micronutrient deficiencies, maybe get an idea of what you think is going on. And again, if you want to talk about that offline, micronutrients are a whole long topic. There's some question about nutrient supplements. So some studies have proposed that supplements actually reduce regular food intake, which we don't want. And they can also cause problems that we know are problems with COPD, anorexia anyways, like bloating, gas, and diarrhea. So I don't know that supplementing Ensure is the answer for this problem. Potentially thinking about increasing food would be a better idea. And you also have to consider the way that you're supplementing that food. So there can actually be some work of breathing when people are eating more, right? Because you're using more accessory muscles. It can be harder to breathe to actually metabolize nutrients. It also can be cumbersome. We kind of talked about that. So work with patients on a shared plan of care. Don't just introduce the idea that they need to do this thing. Think about how it can happen. Also consider refeeding syndrome, which is something that we think about with parenteral nutrition, but it can happen in outpatient and with oral nutrition, and especially with large carbohydrate increase intake. So you may need to consider balancing some of that out. And if you have questions, you can talk to a dietitian, or there's a lot of literature out there about kind of how to do this. The respiratory quotient can actually go up with carbohydrates in particular, and this doesn't mean that a low carbohydrate diet is necessary. By low carbohydrate, I mean, 30 to 40 to 50% rather than getting up into that 60% range. But that may improve outcomes more than having higher carbohydrate intake. So that's kind of what we've got. It's a really brief overview of nutrition and COPD. I attached a couple articles again that talk about the changes and the way that we think about COPD, but just consider that nutrition and COPD go together, both that COPD in and of itself can cause undernutrition, but undernutrition in and of itself can also cause worsening prognosis in COPD. So it's something to be assessing as a part of the disease state. And the better that you can do with managing this, the better that your patients will have in outcomes. All right, so we will talk again when we do our next lecture. Thanks, guys. Bye.